Well, tēnā koutou and greetings to you all. It's great to be here, and it's wonderful to be asked to this. I think this is your last day, isn't it, of this particular meeting, so thanks for asking me. It's fantastic. The first thing that I really wanted to say to you is that you are our flagship program in terms of health, quality and safety, quality improvement initiatives. And you've done so well that you are now actually the leaders right across the country of quality improvement. And you may not have thought of yourself like this, but because this has been so successful, and I acknowledge, all of the hard work that you've done collectively as a collaborative, but also back in your own ICUs and your home base, the hard work that you've put into this, and the demonstration of how successful this is. It's been in the media, government's incredibly happy with you, ministers are happy with you, we're happy with you. But the most important thing is that you have learnt skills about quality improvement that now make you, I think, some of the leaders across the health sector in New Zealand. You know more about doing quality improvement projects than I do, than many people do. And you mightn't have thought about yourselves in that regard, because leaders have an obligation to think about, well, what else can I do? How can I use this knowledge and this leadership to do something else? So what else is there that can be improved? So this has been fantastic, but there's more to be done. It's quite interesting when I took on this role and talked to family members and friends and ordinary New Zealanders who kind of said to me, well, what is quality? And of course, being a psychiatrist, I'm quite used with people not really understanding what I do. And I thought it was quite interesting that I'd moved into an area where people didn't understand either what we do or what quality is. And so I tried to explain, and I was using the central line infection rates as an example. And so people said to me, but why weren't people doing that before? Why wasn't this done before? And I think it's made me kind of think about this a lot, and about how I think as a culture in the health sector, we are pretty accepting of things that go wrong as being kind of, we do our best, and I think every single one of you, every single one of us, every clinician does their very best every day. But there has been a tendency to have an acceptance of, we're a human system, and human systems, things go wrong, and all of that is true. That is true, of course. And, in this role, I've kind of struck this kind of pushback from, sometimes quite senior clinicians. So, for example, in the area of falls, and you know that falls is one of our priority programs, reducing harm from falls, which probably means reducing the number of falls to some extent. And some orthopaedic surgeons have said to me, we don't really believe you can do that. We don't really believe you can reduce falls in hospital, because they're mostly older, frail, demented individuals, and falls happen. They just happen. It's a part of life. And it's quite interesting to kind of have this sort of pushback, but it reminds me of my work in mental health as a psychiatrist. And when I was starting to try and change the mental health system, people would say to me, you cannot reduce rates of seclusion. And you probably know that all acute mental health units have rooms that people who are very disturbed in their mental illness can be secluded in, really for their safety and for the safety of staff, for both reasons. And there were times when these rates were extremely high and people were put into seclusion. That is, put into a room probably usually with nothing in it and a door that is locked. And although they were monitored, sometimes that monitoring was variable depending on how busy staff were. And, I used to think, yes, maybe we can't do this. It is so hard. It is hard. People who are very disturbed and often have the influence of drug and alcohol as well as a psychosis, it is very difficult. But through a similar process to a collaborative, which was led through an international network that I helped start in mental health, through some work that was done in the US, people have worked really hard on reducing rates of seclusion. And there are some acute units, and I don't know if Counties is one of them, not we're in Counties, but I know there are some around New Zealand that have 0 seclusion rates with the same degree of distress and disturbance and so on with individuals. And that's just by having a consistent assessment process, having consistency that everybody does the same thing all of the time, and being systematic, but also putting in and training for new skills. So learning skills from other industry about de-escalation. And the police are much better at this actually, and other industries, about how you de-escalate and how you build positive relationships, working on the strengths of individuals rather than on the negative behaviour that you see. And then how you use measurement to actually drive a process, collecting data and measurement and talking about it and reviewing it and building a team approach of consistency. And that's what you've done, So, amazing and miraculous things can happen when you work together. The challenge, of course, and I know you've talked about this, is then how do you kind of pick one, fantastic program like CLAB and roll out what you've learnt? How do you take it to another area? How do you even take it to another area within your own hospitals? How do you convince your colleagues who probably, are a bit sceptical? And I know that many of you were sceptical. I remember when Associate Minister Goodhue visited Auckland, and this was halfway through the CLAB program, and one of the clinicians actually said, I was really sceptical about whether the bundle, that you use and the implementation of that technique would work. I was sceptical. And so kind of, seeing is believing, You have to kind of do something sometimes in order to bring about a change. And then, people are convinced. So I suppose my challenge to you is, what are you going to do next? What are you going to do with these skills that you've got? There's probably things that happen in ICU that you know much more about than I do. Something like respirator-related pneumonia. Sometimes things are complex and hard to measure. How do you start? How do you convince others? And maybe we can engage in a conversation about this. And I know you've kind of reflected on maybe what convinced you to do this. Maybe it was evidence, reading about this work internationally, or even reading about it in New Zealand, or being presented evidence. Maybe it was a charismatic leader that convinced you, someone that you really believed in, someone that you liked and you knew and thought, oh, well, if they think this, it must be okay. Or maybe it was just being prepared to try it. Just, let's try it and see. And the kind of seeing is believing syndrome. But the important thing about that is that the collection, having a data or information-driven process is absolutely vital. It's important to have good data. It's important to be able to understand it and analyse it properly and use it in a useful way that kind of changes practice. And I guess the other important thing about working with other people is that you then create relationships of trust, so that you get to know others that are working across the country, you begin to know who they are, you begin to like them, you begin to have fun together, begin to trust them, you create a safe environment for being able to make mistakes and to admit your mistakes and to admit being open about what you're doing. And that's really important in terms of change. So the other issue, of course, is teamwork, is creating a team of interest and working together, not just nationally, but in your own area. And I know David tells me that you've been talking about what you think the good things are. So I've probably only just highlighted a few, and there's probably a whole lot more that you've talked about. And I'd be interested to hear about that, because it's important for us to know in the Commission how we take you as leaders and your skills and use them elsewhere. We're trying to build networks regionally and locally, and you'll hear much more about this as the year goes on. We'll be launching a campaign on patient safety in April, where our 4 priority areas will be phased through this campaign. So the first area will be reducing harm from falls, but infection will come up. Reducing harm from infection, or reducing infections full stop, will come up in one of the phases. And part of our process is to build regional networks of leaders in quality improvement. Clinical leaders, quality improvement advisors, champions for the particular areas, and to use that leadership to help drive local change and development. So you're the flagship, you're at the front of this, so we'll be tapping on your shoulders and wanting you to step up and use your leadership skills elsewhere. I thought that I'd tell you about the International Initiative for Mental Health Leadership, which is the network that I alluded to, that's now 10 years old. There's about 8 participating countries, all English speaking, that is a kind of international collaborative of leaders, both at government level, but also at local and level right throughout these 8 countries. But there are other little collaboratives within it. So there's a little collaborative around seclusion and the use of it, around suicide prevention, for example, and issues like that. But at this, we've got the network meets once every 14 months, and it's New Zealand's turn after 10 years again. And Professor Sir Mason Dury was the speaker last night that opened it, and he talked about, I just thought I'd repeat the 4 themes that he talked about, which are kind of universal to what we try to do in health. That being global is everything, that we are so internationally connected that what we do affects other countries affect us, whether that's economically, or in health or infectious diseases or whatever. So global is you all know about that. It's very fast. It's been, it's faster than it was 100 years ago, but even infectious diseases spread globally 100 years ago. However, local is important. So, and you found that out, that you can pick something up that's an international program or a national program, but how you engage and implement it in your local area is different. So Wellington's different to Auckland, Dunedin's different to Whangarei. You know that. So everything is global, but local is important. The way you get things done is by distributed leadership. And all of you demonstrate that. So it isn't just about one guru at the top. It's about how all of you as leaders engage with others and use your leadership skills to bring about change. Distributed leadership is about networks. It's about collaborating through those networks. And finally, that we all have 2 aspects of things that we focus on all of the time. We're involved in illness, that's ill health, but we're also involved in health. So you're involved in addressing and tackling the issues of ill people that come into intensive care units, but you're also there to prevent further harm from happening, to prevent further harm. So there are two things always that we're engaged with. I mean, in the bigger sense, that's about how you prevent illness, so the prevention, health, how we all remain healthy till we're 103. Dr. Hutchinson was telling me, 103, he hopes to live to. But how we deal with illness when it arises. And finally, I just leave you with a quote. You know, there's quotes all over the place here, and I don't know whether there's this one, but I came across it the other day by Helen Keller. Alone, we can do so little. Together, we can do so much. So thank you.
You hang around?
Yeah, I hang around people too.
It'd be good if you've got any questions for Janice about the work or reflections on your experience throughout the program to date. Maybe you could talk to Janice about that now, or she's going to be around this morning. So it would be really good for those people who have been actively engaged in the work to have the chance to speak with Janice, because I think the challenge she's put out to us about how do we make use of what we've created in the future is actually it's a gift, you know, that we shouldn't ignore, because I think that, you know, if we come up with credible work programs, you know, I'm pretty convinced that we'll find support to put those work programs into action. So if there are people who'd like to say something about the work that they've been engaged in to date. Dave, how about, can I put you on the spot a little bit about the South Island network that you've sort of worked with?
What is it you want me to talk about?
I'd like to say, what has this work done with regard to your relationships with other intensive care units in the South Island?
Well, I think one of the key things is we actually recognise people, their faces and a bit about their personalities. I'm looking around this room, this table now. They're sober personalities in terms of what they're like, what the strengths are with each of the individual units that we practice with. It's been extremely positive for us, such that when we're talking about non-CLAB issues in the middle of the night, we know exactly who we're talking to on the other end of the phone. It's actually been very positive for us in the South Island. It's allowed us to generate some funding to allow permanent telehealth communications between ourselves and the West Coast, which will be coming online. So this has been a catalyst, if you like, for trying to integrate our services away from the silos that we've traditionally practiced in, such that we're delivering health, I think, now to the whole of the South Island rather than just to our region.
You just remind me of something that I didn't really say.
Sorry about the one microphone.
I know. And that is that although this is a face-to-face meeting, that many collaboratives and that kind of structure, you know, working together, supporting each other, knowing each other, can be done electronically or through the virtual world, or webinars, of course, as well. And that I think we need to think about that more and more, because, of course, we need scarce dollars to go as far as possible. I think face-to-face meetings are really important. Getting, you know, drinking lots of wine and good restaurants together is really important. Getting to know each other, really good. But building on that through the virtual world. And, you know, I think this is a really important collaborative, and I think we need to think about how to help you do that in an ongoing way.
Okay, good. We might move on. It's a perfect introduction to Sean's presentation. Thank you very much, Janice.